هيكون في مجموعة من الحالات، وحضراتكم بتجاوبوا عليها عن طريق الشات، وأنا بعقب على الإجابة، وإن شاء الله يكون الموديول يعني كويس بالنسبة لكم بإذن الله تعالى. الحالة الأولانية and this is the first case. This is
recording in progress.
A male patient 35 years old, and this is MRI T2 weighted images, axial also image, and the sagittal the coronal image. And what do you think? Okay, then this is the common bile duct stones is the part of the answer, and the second part is the lesions in the liver, and you can see that the intrahepatic biliary radicals are somewhat dilated, and there are some cystic changes connected to the biliary radicals, which is one of the criteria of Caroli disease. And then this patient had Caroli disease as well as multiple common bile duct stones. Then naturally this is the second case, and you can see the answer projected by mistake. And you know that the presence of some pelvic fibulae is a well-known finding in everyday practice, but whenever the fibulae are extensive, as you can see in this particular case, then you think of a hemangioma in the pelvis, and this is the case where you got a soft tissue mass which is surrounding the rectum and pushing the bladder, containing the fibulae seen in the plain film, as well as showing some areas of contrast enhancement, which is a classic diagnosis of a hemangioma in the pelvis. Then the second case is a female patient, 48 years old, with fever and right upper abdominal pain. This is CT before contrast, and this is CT after contrast. Um, Portal vein thrombosis or cholangiocarcinoma. No, these answers are not right. Actually, you can see some, let us say, calcifications or stones within the bile ducts. And after you give some contrast material, then if you compare the density of the stones by the density of the enhanced liver, and you got some difference in the appearance. And also you know that the presence of stones or calcifications in the biliary radicals is diagnostic of oriental cholangitis or biogenic cholangitis. And you know also that these stones can be seen also in cases of sclerosing cholangitis, but is not as frequent as to be seen in the biogenic cholangitis. Then, if you see multiple calcific shadows within the liver parenchyma conforming with some of the channels, and you think that this is portal venous radicals, you know that there is no calcium in the portal vein, but calcium may exist in the bile ducts, and this is a case of biogenic cholangitis. Then the next case is for a patient with CT of the abdomen after contrast enhancement obtained in the arterial phase. And you see here an abnormality. Yes, and there is any problem in the sound. Do you hear me very? You hear what I'm saying?
We can hear you, Dr.
Okay. Then, what do you think of this case? Okay, and the lesion is in the stomach, but this is not a gastric varices. Always you can see here that the gastric mucosa is markedly hypertrophied and enhanced. And you see the gastric rouge very, very prominent. And you know, when you are confronted by a case like this, this includes some of the differential diagnoses like hypertrophic gastritis, like Menetrier disease, and also the possibility of Zollinger-Ellison syndrome should be considered. And this was a case of Zollinger-Ellison syndrome. You know, the syndrome is composed of a triad of gastric hyperacidity, multiple peptic ulcers, and the pancreatic non-islet cell tumor. Then you know that you may say that lymphoma is also one of the possibilities, but lymphoma can do not respect the gastric rouge like this pattern.
Recording in progress.
Okay. Is there any problem in the internet?
Recording stopped. Recording in progress.
Dr. Mamdouh, we can't see your screen.
نعم.
Uh,
انت سامعني؟
we can't see the screen. No screen.
ايوه يا شريف.
Recording stopped.
سامع حضرتك بس الصوت يعني مش واضح أوي.
الصوت بيقطع. اوكي. يعني كده سامعني كويس؟ الو.
أيوه كده سامع حضرتك.
كده كويس.
سامع الصوت بس مش شايفين الشاشة.
طب شفت الشاشة دلوقتي؟
لسه
امم
لسه مش من الشاشة.
طيب نعملها من جديد. اوكي.
كده
كده
شفنا بدأ كده شفنا الشاشة.
طيب كده شغال تمام.
تمام كلنا شايفين وسامعين.
Okay, sorry for this
Recording in progress.
interruption, and we have discussed this as a case of Zollinger-Ellison syndrome. Now we go to the next case where you see an contrast enhanced CT scan of the abdomen as well as a coronal image. What do you think? Yes, and this is the right answer. This is acute appendicitis. The appendix is swollen and is the wall is thickened and enhanced, surrounded by a stranding of the fat around. And also in the coronal image, you can see the same findings, but you cannot appreciate the presence of appendicolith, which is present in about 90% of the cases, and still there are 10% of the cases with no evident obstructive lesion. And this is a case of ultrasound of the abdomen together with axial and coronal post-contrast CT scan of the abdomen. Yes, the answer is right, and this is a case of lymphoma. And you see that the spleen is enlarged. There are multiple focal lesions in the spleen. Also, you see focal lesions in the liver, together with the presence of bulky abdominal lymph nodes around the root of the mesentery, and also seen well in the axial image. The case was a non-Hodgkin lymphoma B cell type. Then this case is for a female patient, 68 years old, and she was suspected to have a pancreatic head tumor by ultrasound. Hydatid cyst, no. Duodenal wall hematoma, no. And this is a classic appearance of an aneurysm. Yes, the answer is right. And an aneurysm, is a mass with an internal patent lumen showing contrast enhancement, and an external thrombosed lumen shows hypodensity, and then you can see the atheromatous calcification in the wall of aneurysm, and this is diagnostic that this is not a dissecting aneurysm, it is just a secular aneurysm, but the origin of this aneurysm is the hepatic artery. Then you should remember this because this is not calcium, of course, this is contrast enhancement, and this feature is almost classic of an aneurysm. Then the next case is a CT of the abdomen, and in the axial and the coronal planes after intravenous and oral administration of contrast material. Okay, I feel that this is a difficult case, and let us explain some of the findings. This is a simple cyst in the kidney, and this mass belongs to the bowel, since he can see that there is gastrografin going through the lesion. And this particular bowel lobe is markedly dilated, and this fit with the diagnosis of lymphoma. And this is right because one of the major features of lymphoma is what's known aneurysmal dilatation of the bowel lobe. And this aneurysmally dilated bowel will show some of the orally administered contrast material together with some of the stagnant food in this dilated loop. And this case is for CT abdomen with contrast in the arterial phase and the corresponding angiographic image of the same case. There are two focal lesions in the liver. One lesion is big and the other lesion looks to be inside the major one. Yes, very good. This is an FNH. This big lesion is a focal nodular hyperplasia with the classic central scar, and on the angiographic image you got extensive hypervascularity of the lesion, and it's not a frequent finding to see and one of the vessels inside the lesion to go aneurysmal dilatation. And this is an aneurysm inside a focal nodular hyperplasia. Of course, the focal nodular hyperplasia is usually in the range of 5 centimeters in diameter, but you know that some of the lesions may reach a bigger size, and still you got the classic appearance of hypervascularity as well as the central scar. It's not that common to see an aneurysm inside the lesion itself. This patient is 1 year old and presented by Bailey's mass that accidentally detected by the mother. That it's cyst, no. Yes, lymphangioma is right. Yes, and lymphangioma is one of the lesions that can be seen frequently in the peritoneum. It is a multilocular cystic lesion commonly seen in the pediatric age group. And this is not a mesenteric cyst, since I have mentioned in the lecture that mesenteric cyst should be in the back of the list of cystic lesions in the peritoneum. And on the top of the cystic lesions in the peritoneum is the gut duplication cyst, whatever it is from the stomach or the small bowel. And whenever you see that the cyst is multilocular, think of a hemangioma. If you see some fat content, think of a dermoid cyst in the peritoneum. Okay, and this is a selected CT scan of the pelvis in a patient with a lesion in the rectum. No, this is not rectal cancer because the mucosa is not destroyed and the segment is too long. Lymphoma is not also ulcerative colitis. This is not the
Recording
appearance of
stopped.
ulcerative colitis. You know that the appearance of the mucosal pattern, which is similar to the accordion like appearance, is one of the pathognomonic features of pseudomembranous colitis. And actually, this pseudomembranous colitis can affect the entire colon, but it can affect a segment like the rectum or the right side of the colon with stranding of the pericolic fat and some
Recording in
fluid
progress.
in the some fluid in the pelvis, and the answer pseudomembranous colitis is right. The next case uh, is a CT scan of the abdomen in the axial and coronal planes, and it shows some lesion in the retroperitoneum, and this lesion has extended to involve the kidney. Uh, no, there is no history of trauma. Lymphoma is right, and this is a case of retroperitoneal lymphoma involving the lymph nodes that has invaded the kidney, and you know that lymphoma of the kidney may arise inside the renal parenchyma and may be the extent of a nearby lymphomatous lesion like retroperitoneal nodes and lymphoma of the adjacent structures. This patient is 50 years old with acute cholecystitis, diagnosis a few days ago, and now is presenting by fever and pain. There is actually no evidence of perforation, and you cannot see fluid in the pericholecystic area, and this is cholecystitis, right? But it's not an ordinary cholecystitis. You got marked dilatation of the or distension of the gallbladder that may lead you to think of an embolism. This is a good possibility, but also there is one of the let us say the criteria. If you look carefully here, you see that this wall of the gallbladder is more or less enhancing, and this wall of the gallbladder is not enhancing, and this is considered by the literature is an initial sign of the development of gangrenous cholecystitis. Actually, this is an let us say a very weak sign, but if you see it, you can prevent the progression to perforation of the gallbladder. We can diagnose gangrenous cholecystitis based on the presence of air in the wall of the gallbladder, which means that there is impending perforation of the gallbladder. And this is the case of the pelvic floor showing the anal canal and the T1, T2, and the contrast enhanced fat sat image. Yes, and this is very anal fistula and abscess. It's not grade 2, it's grade 4. The fistula has extended across the external sphincter, meaning that it is grade 2. Just a transsphincteric extension is grade 2. But if there is a branch or, grade 3. Grade 3 is extension across the external sphincter. If there is an abscess or side branch, you consider grade 4. And this is grade 4 perianal fistula with abscess formation in the SQ anal fossa. This patient is 63 years old, presented by intestinal obstruction. And the cause of obstruction is present in this CT image. No, it's not diverticulitis. Actually, this is not a lesion and not a sigmoid cancer. If you look carefully here, and you can see this appearance, which is the combination of a soft tissue density together with air loculi, and this lesion is located inside the bowel, and it is the cause of obstruction, and this represents a small bowel bezoar. Actually, and the foreign body is a good answer, but if you say that this is bezoar, this will be more precise. And bezoar is frequently seen in the stomach, sometimes seen in the duodenum, but rarely seen in the small bowel. The next case is a CT scan of the abdomen after contrast injection. Yes, and the answer is good, right? Gallbladder carcinoma. There is a mass inside the gallbladder showing contrast enhancement. And you know that gallbladder masses may be in the form of polyps or carcinoma or even metastasis. And we consider the polyp that is more than 1 centimeter in diameter towards the malignant side. Then we consider the possibility of gallbladder carcinoma, and if there is a known history of primary malignancy, you consider a metastatic deposit to the gallbladder. And this patient presented by intestinal obstruction, and the cause is also present in the scans. Crohn's disease, no. And this answer I think is good. Gallstone alias, and this is the right answer. If you look carefully, and you can see all the triad of gallstone alias. Number one, you got the radiopaque stone within one of the dilated bowel loops, usually in the terminal ileum. Number two, you got some evidence of intestinal obstructive changes in the form of dilated bowel with air fluid levels. Number three, you got air inside the biliary radicals, the common bile duct, and some of the intrahepatic biliary radicals, and this is gallbladder ileus. The next case is an MRI on the liver uh, before contrast and after contrast with early and late films, and the diagnosis of hemangioma is right, and this is a classic appearance of hemangioma showing the peripheral nodular marginal enhancement with progressive fill-in after contrast injection. And this case with acute pelvic pain, the CT scan showed some lesion in the sigmoid colon, and the diagnosis of diverticulitis is right. All the criteria of diverticulitis are present in this images. Number one, the presence of patent diverticuli in the wall of the colon. Number two, significant edematous changes of the wall encroaching on the lumen. Number three, stranding of the pericolic fat. The next case is a female patient, 36 years old, with progressive abdominal pain and vomiting for 1 week. And you see a big lesion in the lower part of the abdomen. And duplication cyst is not a cyst. This lesion is not a cyst and is not gastric volvulus. The stomach is in its side, and the volvulus usually go up, not down. And this is not a gastric tumor and not a dermoid lesion. This is a wandering spleen. And if you look carefully in the left hypochondrium, you cannot see the spleen. and the spleen has left its anatomic location and is now located in the pelvis, together with, let us say, torsion of the wandering spleen, and consequently cut of its blood supply, and the spleen is totally infarcted. Then actually this is a difficult case, but it needs you to imagine the situation. The spleen is not in its side, and you consider if this is a normally enhancing spleen, you can easily diagnose this as wandering spleen. But consider that wandering spleen is liable to torsion and to strangulation of its blood supply, and then you got infarction of the spleen, and this is infarcted wandering spleen. And this patient is 25 years old. She has 2 weeks of abdominal distension, but no fever, and she has highly elevated CA 125. Before you answer, the elevation of CA 125 is an indication of ovarian cancer, but sometimes this tumor marker is elevated, irrelevant to the ovarian carcinoma. Then, if you diagnose this as omental deposits, it's good. But there should be some of the differential diagnoses, um, mesenteric metastasis, pseudo. No, this is not a pseudomyxoma peritonei because of the absence of the scalloping of the edges of the liver. You know that the omental thickening is maybe either an inflammatory pathology or a neoplastic pathology, and the neoplasm is usually towards the metastasis, but the inflammation is pointing to the most common lesion seen in our country, which is the TB. Then you may think that this is TB peritonitis, but you do not have any clue to suggest the diagnosis of TB compared to the malignant lesions. And malignant lesions may be also primary, like lymphoma or peritoneal leiomyosarcoma, for example. But commonly, these peritoneal lesions are of metastatic nature. Then how to proceed with for the evaluation of this case? You just go and have a sample from the acidic fluid, or better, you got a core biopsy from the omental cake in order to reach the diagnosis. The next case is a patient with a small bowel obstruction. You can see the obstruction in the coronal film, and also you can see the cause in the axial image. This is not the sigmoid, this is a small bowel. And sigmoid is a little bit in the lower part of the abdomen, and this is Crohn's disease, of course. This is a small bowel lesion. The colon is here and is not affected, but this is a long segment of mural thickening and enhancement encroaching on the lumen, causing proximal obstructive changes, and is diagnostic of Crohn's disease. This case is a patient with obstructive changes in the bowel with progressive vomiting, and nothing stay in his stomach. And this is some of the sections obtained after oral administration of contrast material as well as intravenous contrast injection. And the answer is right. This is the superior mesenteric artery syndrome. You can see easily the very short distance between the aorta and the superior mesenteric artery with consequent compression of the third part of the duodenum and the proximal dilatation of the duodenal loop. And if you see upper sections, you can also got dilatation of the stomach as well. This is right. Superior mesenteric artery syndrome is frequently seen in the clinical practice. You know that the distance between the superior mesenteric artery and the aorta is about 8 millimeter or more. And if it is very narrow like this, in the this will compress the third part of the duodenum, and you got intestinal obstructive changes. This patient is female, 20 years old, with sudden severe colicky, non-colicky pain in the upper abdomen. There is no history of trauma. And the scans showed mass with lobulated margin in the peritoneal cavity. Yes, I expected you to say that this is lymphoma, but actually, it's not well demonstrated here that the mass is of fluid density, and this is also a case of lymphangioma, and this is the surgical gross appearance. But if you failed to appreciate the density of the fluid, you may say that this is a case of peritoneal lymphoma. And this is the appearance of the lymphangioma in the abdomen, big cystic lesion with internal septations, and there is no solid components and no calcification, and it go through within the bowel loops, or may be confined to the omentum, as you can see here. And these are the differential diagnoses for the cystic lesions in the peritoneal cavity, like pancreatic or non-pancreatic pseudocyst, pancreatic cystic neoplasms, especially the mucinous type, and because it has large size. But
Recording stopped.
intraductal papillary mucinous neoplasm is a small lesion. And also you may see the pseudopapillary tumor, hemangioma, paraganglioma, some pancreatic lesions with cystic degeneration like adenocarcinoma, islet cell tumor, metastasis, and cystic teratoma.
Recording in progress.
Also, you got through epithelial cysts like those seen with von Hippel-Lindau or autosomal dominant polycystic kidney disease, and the lymphocyte if there is a history of surgery. This patient had hematochezia and signs of intestinal subocclusion. Yes, the answer is good, and this is superior mesenteric artery thrombosis and intestinal ischemia as well. If you look carefully here, and you can see the thrombus in the superior mesenteric artery and also in the sagittal image. And you also see that the bowel loops are dilated, and the wall of this particular bowel is not that enhancing compared to the normally enhancing bowel. Then this is an occlusion of the superior mesenteric artery with mesenteric ischemia, and you may be able to see also some of the air loculi in the wall of the ischemic loops. What do you think of this? Yes, and you think about the anatomy, and this is the region of the appendix, and you got what looks like an abscess or perforated appendix with periappendiceal inflammatory mass. The answer is right. This is perforated appendix, and you got some internal air loculi. This is a female patient, 17 years old, with a big neoplasm in the liver. Yes, and this is a straightforward case of fibrolamellar hepatocellular carcinoma diagnosed by the age of the patient, of course, and the size of the tumor and the absence of cirrhotic liver changes. There are a lot of criteria separating the fibrolamellar type from the usual hepatocellular carcinoma. This patient had an altered bowel habits with watery diarrhea. No, yes, and this is rectal villus adenoma, the carpet-like structure which is expanding the colonic lumen and has a characteristic velvet-like appearance. This is diagnostic of villus papilloma in the rectum. And this male patient, 49 years old, presented by fresh bleeding from the anal canal. No, this is not hemorrhoids. This is an actual mass. And you see that there is a mass involving the circumferentially involving the anal canal, and anal cancer is the right answer. And also, you deal with masses in the anal canal as similar to masses arising in the rectum. You think of malignancy first, then we may go to the other possibilities. This patient is 60 years old with a mass in the liver. This is CT, and this is MRI T2, and this is diffusion, and this is ADC. Yes, this is a straightforward case of hepatocellular carcinoma, the most common solid hepatic tumor in adults, and show the classic appearance of enhancement and diffusion restriction. This is a male patient, 69 years old, with rectal bleeding. Okay, and the answer is shown. And this is rectal carcinoma, but you should say that this is the mucinous type of the adenocarcinoma because of the bright signal and the T2 weighted images. This will not make so much a difference in the management, but it is better to say that especially in the exam, whenever you see that a mass in the rectum that is significantly bright in the T2 weighted images, and you think of the mucinous type of the adenocarcinoma. Then this patient with masses in the and the upper abdomen and evidence, of course, of intestinal obstruction, multiple air fluid levels. The patient had abdominal distension with history of bowel surgery 2 years ago. And these are the yes, the answer is B, and this is right. This is pseudomyxoma peritonei because of the classic appearance of the scalloping of the hepatic surface as well as the splenic surface together with intestinal obstructive changes. Of course, these obstructive changes has no relation to the pseudomyxoma peritonei. This patient had carcinoma of the ovary and focal lesion detected by ultrasound. Then MRI was obtained to verify the nature of this focal lesion. No, this is not metastasis. Hemangioma, right? This is the classic appearance of hemangioma. Bright signal in the T2, nodular marginal enhancement after contrast, and T2 shine through in the diffusion weighted image and ADC. These are the features that can separate hemangioma from metastasis safely whenever you are looking or evaluating a patient with primary carcinoma. This patient, male 43 years old with abdominal pain. Yes, and this is pseudopancreatic cyst, classic appearance. The most common unilocular cystic lesion in the pancreas, and this is pseudopancreatic cyst. And this patient had intermittent epigastric pain, and the pain had been getting worse and signs of peritoneal irritation. This is the supine film, and this is the brown film of barium meal study. Now, an annular pancreas is not relieved by the brown position. No, this is not carcinoma of the stomach. The stomach is good, and the mucosal surface is intact. No, and this is not lymphoma. I know that you are not familiar with barium studies, but this is a classic appearance of superior mesenteric artery syndrome. And you got abrupt obstructive changes in the third part of the duodenum corresponding to the site of the superior mesenteric artery with proximal dilatation of the duodenal loop. And these changes are somewhat relieved by the brown position since the superior mesenteric artery will be somewhat away from the aorta. Then you got some relief of the symptoms. And I know that you do not see these findings, but we are used to see these findings very frequent in the era of barium studies. But now we depend on the CT scan to diagnose this lesion. This is a female patient, 67 years old, with non-cirrhotic liver. The alpha fetoprotein is normal, and she has abdominal discomfort. Spleniole, where is this spleniole? The lesion is in the liver. No, This is not fibrolamellar hepatocellular carcinoma. The patient is old and the lesion is hypervascular enhancing in the arterial phase, and this is the focal nodular hyperplasia, and this is selective angiogram, which is usually the way to treat this lesion by embolization. This is focal nodular hyperplasia with attempt for embolization. This is the female infant, 7 months old, with a big mass in the liver. Yes, and this is a straightforward case of hepatoblastoma, one of three common masses in the pediatric age group: the hepatoblastoma, the nephroblastoma, and the neuroblastoma. This is a female patient,
Recording stopped.
77 years old, with abdominal pain and a distension for several years, and this was attributed to her old age. Yes, and this is a good answer. This is simple hepatic cyst, a huge simple hepatic cyst, and you know that it is arising from the liver by the clue sign, which fits also for kidney lesions, and the
Recording in
simple lesion
progress.
is made of clear fluid density with no internal septations, no calcification, no enhancement, and no mural nodules. This patient is 70 years old with hypochondrial pain and jaundice. Yes, and this is pancreatic mass, and the only well-known, most common mass is pancreatic cancer, and this is carcinoma of the head of the pancreas that has obstructed the main pancreatic duct, and the duct is markedly dilated with atrophic changes in the pancreatic body and the tail. And this is a CT scan non-contrast, and this is MRI T2 weighted image of diffuse pancreatic lesions, and this is not chronic pancreatitis in spite of the presence of some calcific foci, but this calcium is not the main dominant feature. There is marked swelling of the pancreas, and there are a lot of cystic lesions. Pancreatic cystosis is a good possibility, but my advice to you, if you see numerous pancreatic cysts, especially if no other cysts are present in the liver or the spleen, then you think of von Hippel-Lindau syndrome, and the pancreatic cysts are present in about 42% of the cases with von Hippel-Lindau syndrome. They are usually totally asymptomatic. This patient presented by nausea, vomiting, and right iliac fossa mass. Um, I don't know. This diagnosis is terminal ileitis. No. The intussusception. No. Intestinal obstruction, yes, but what is the cause of intestinal obstruction is this cecal mass. And you got an heterogeneously enhancing mass involving the cecum and maybe the terminal ileum as well. associated with proximal intestinal obstructive changes, and this is due to cecal carcinoma. Then this CT scan of the abdomen, the arrow points to the superior mesenteric vein. And do you think that there is an abnormality in this vein or not? Yes, the site of the vessels is not normal because the superior mesenteric artery is usually to the left of the superior mesenteric vein. Sometimes you got this abnormality, and this abnormality is not associated with intestinal obstructive changes nor mesenteric volvulus, since the diagnosis of volvulus needs the Worley sign and the total absence of the superior mesenteric artery and vein. This patient is hemodynamically unstable and with hematochezia. A CT scan before contrast and after contrast was obtained. No, this is not ischemia of the bowel. But if you look carefully here for this particular loop in the pre-contrast study and in the post-contrast study, you can see significant contrast enhancement and what looks like vascular abnormality in the wall of this bowel. And this, of course, is a vascular lesion, which is the cause of bleeding. And this was found to be an angiodysplasia, and you can also diagnose this not as an angiodysplasia, but as an abnormal vascularity in this bowel loop, which should be verified after that by angiography. This is a male patient, 60 years old, with long-standing abdominal discomfort. On examination, he was found to have a large mass in the abdomen. Yes, and an exophytic mass from the stomach or even from the bowel is a good diagnosis for GIST tumor, which is the gastrointestinal stromal tumor. And this name has replaced the leiomyosarcoma of the stomach, and also the leiomyoma of the stomach are both replaced by the GIST tumor. This female patient had progressive worsening epigastric pain. And this is the initial CT scan, and this is a follow-up CT scan done 4 days later. And no, this is not a pancreatic abscess because of the absence of air inside the lesion. If you know that this is a pancreatic cyst, yes, this is a ruptured pseudopancreatic cyst. And I just have said that the most common unilocular cystic lesion in the pancreas is the pseudopancreatic cyst. And after 4 days, the cyst is very small with extensive stranding of the surrounding fat and the fluid in the peritoneal cavity, meaning that the cyst has ruptured. And this is a spontaneous rupture of a pseudo pancreatic cyst. This patient is 62 years old, and this is selected images from an abdominal scans obtained after contrast injection. Yes, this is the right answer. Crohn's disease, multiple segments of mural thickening and enhancement encroaching on the bowel lumen. The only diagnosis is Crohn's disease. Of course, you may say that this is an inflammatory bowel disease, and if you are asked about the differential diagnosis, the lesion which is most common in the small bowel is Crohn's, while that in the large bowel is the ulcerative colitis. Okay, this patient is 80 years old with abdominal pain and fever. Yes, the answer is right, and this is wandering spleen, but in this case, the spleen is viable and is homogeneously enhanced. And this goes what I have with what I have said before. If the spleen is intact, concerning its vascularity, it is easy to diagnose wandering spleen. But please put in your mind that wandering spleen is liable for ischemic changes because of the torsion of its vascular pedicle.